co-hosting this event with Erica Ruggiero in the Office of Global Health, and she's going to be here after her course ends at noon. And it's my great pleasure to introduce Professor Peter Berman, who's joined us from UBC, where he's the director of the School of Population and Public Health. A relatively new role where he comes from the US. He was poached from Harvard, and where he had spent a long time in his career studying global health, and interspersed with about 8 years at the World Bank, and spent many years in Indonesia. And all that to say, he's the perfect person to invite to speak on the topic of universal health coverage, and I'm really pleased to have this opportunity to hear from one of the leading scholars in the world on this topic that we're all keenly interested in, from a comparative perspective, but also in our Center for Global Health that we're launching tomorrow. So I'll turn it over to Peter. We're going to start with the lecture, and because we're video recording, we would ask that you keep your questions to the end. There will be plenty of time for questions and discussion afterwards.
Okay, great. Thank you, Sarah. So thanks, Sarah, and thanks to colleagues here from the North American Observatory, and I guess I have to stand up here to change the slides, right? Yes. And to the U of T Dalalana School. It's been, as Sarah said, I'm pretty new to Canada, and it's been great fun for me just to spend a couple of days with colleagues I'm getting to know, and hopefully we'll be doing more. There'll be more opportunities for us to work together in the future. Now, it's going to be a little challenging to show you some of the slides that have some data in them, and I will try to talk our way through them. But for those of you who are sitting at least on the side of the room, you might want to scooch your chairs a little down towards the front if you want to see better. Up to you. Thanks to the North American Observatory for inviting me, but I'm not going to talk much about North America. And they told me that was okay. But the question about universal health coverage is very relevant in North America as well. Maybe at the end of this, we can actually explore that a little bit and thinking about what it means in the context of North America. Just to start off, no conflicts of interest or sources of bias to disclose in relation to this presentation. At UBC, I always start my talks with an acknowledgement of the privilege of working on the traditional unceded and ancestral territories of a nation or nations of people whose identity I don't know here in Toronto. But whoever they are, I acknowledge the privilege of being here today on their territory. So, a bit of an outline of what I'm going to talk about. I want to dig into, this is kind of a high-level presentation on universal health coverage because it has become such an important topic of conversation in global health. And I think there are some really interesting things about the way the conversation has developed that are not all that well understood and have caused some uncertainty or confusion. And then also, this is a particularly important moment to take stock of things because in September 2019, at the UN General Assembly, there was also a major stock-taking of progress towards universal health coverage, and it raised some important issues going forward. So I'm going to explore some of the definitions, look at where UHC sits in the Sustainable Development Goals that the world adopted as goals and targets to 2030. Look at the whole question of monitoring progress towards UHC and the work that's being done by the international organizations to do this, and maybe we can explore a little bit critically what this work tells us and what it doesn't tell us. And then share with you what the recent reporting told us about progress in lower and middle income countries towards achieving UHC by 2030. And then maybe at the end we'll have some Q&A and we can actually since we're here at the North American Observatory, we can actually ask the question, how is Canada doing in terms of achieving UHC? Most people in the United States think Canada has achieved UHC. Curious to see what you think about it. And this is certainly an ongoing issue in the United States, and I know the North American Observatory focuses as well on Mexico, and it's certainly an issue in Mexico as well. We could talk about that. Okay, so what is universal health coverage? The major sort of policy statement about this began in 2005 at the World Health Assembly, and that defined universal health coverage, that a health system that achieves universal health coverage would be a health system that guaranteed access to all necessary services to everyone while providing protection against financial risk. And I added the items in brackets because they're implied in the statement, but they weren't actually in this sentence. And I think it's important to kind of think about this from a health systems or health system performance perspective. I would say that this is a very high-level goal, and a health system that achieved this goal would be producing the highest attainable outcomes that we can anticipate a health system is able to achieve. All health needs would be met. We could add a corollary at an adequate level of quality to produce the outcomes intended, right, for everyone, as well as protecting people against financial risk. And in the framework that I use to think about health systems, health outcomes, financial risk protection, and citizen satisfaction, I think this would be, attaining this goal would achieve the best possible health outcomes, the best possible financial risk protection, and I think it's fair to assume that that would be a system that people would be fairly satisfied with. Okay, so certainly a high level of satisfaction. And Margaret Chan, then the WHO Director General, remarked that she regarded UHC as the single most powerful concept that public health has to offer. So this was a pretty high-level endorsement of this as a priority. The Sustainable Development Goals, launched in 2016, that followed the Millennium Development Goals that were put in place by the UN community around the time of the change in millennium, but actually tracked progress on 8 measures, 8 goals from 1990 to 2015. There are 17 SDGs. They cover a very broad range of aspects of development. It's very interesting to contrast the MDGs and the SDGs. The SDGs resulted from a much wider consultative process with many international interest groups, and they cover many, many different areas of individual and social well-being. SDG 3 is entitled The Focus on Health and Well-being. Keep that in mind because it's not just health, it's health and well-being. It has 13 targets. UHC is one of the targets. And of course, this has given rise to this very sizable global movement in support of UHC, and multiple resolutions in the United Nations and the UN General Assembly. There's a global advocacy organization, UHC 2030, and you can look them up online. And as I mentioned, this year's General Assembly in 2019 hosted a high-level meeting on UHC progress. And this was seen as a really important stock-taking moment. And in advance of this meeting, 2 major reports monitoring global progress towards UHC were issued, and then there was a political declaration issued at this meeting, signed onto by heads of state, almost all heads of state who attended the General Assembly. This, if you are interested to go back to the history of this political declaration, it actually took quite a long time to work it out because there were certain areas that were considered somewhat controversial among some of the countries that it was hoped that they would sign, including the United States, by the way. But it did actually get issued as a political declaration. These are the cover shots of the 2 major reports that were issued right at the time of this meeting. There's a web link there. They're downloadable. You can read them. They're very long reports with many appendices and data charts and so on. I'm going to share some of the results that we found in these reports. But You can see that one of them focuses on primary health care, and the second one on financial risk protection. And so there's pretty comprehensive data that's now been assembled in support of this question, how are we doing? So before we get into that, let's talk a little bit about the political declaration and how that evolved. So this is just some quotes from the declaration. We, the heads of government and representatives of states and government, assembled at the UN, September 2019, strongly recommit to achieve universal health coverage by 2030. So that's SDG 3, goal 3.8, achieve universal health coverage by 2030. Then it goes on with various and sundry references, as UN declarations often do, and discusses specific elements of health development for 56 specific paragraphs. So if you read it, you will see that just about every stakeholder group in health and health systems got their paragraph in there, assure essential drugs, make sure sexual health, there's everybody's got their particular goal in there. But the overall statement really was in this one, to progressively cover 1 billion additional people by 2023 with quality essential health services and quality, safe, effective, affordable, and essential medicines, vaccines, diagnostics, and health technology, with a view to covering all people by 2030. And the UN Secretary General then is asked to engage all the member states to do what they need to do, and a follow-up meeting in 2023 will be held. So what is UHC actually? And I think that if you explore these documents, you'll see that there's some uncertainty in the way this has been discussed internationally. I showed you the quote from the 2005 World Health Assembly, which talked about all necessary services for all people without undue financial risk. Okay? And I like to think about this as something you might call comprehensive UHC. So it's all healthcare needs met by all relevant health services without undue financial risk. But as you saw just now, the SDG doesn't talk about all health services. It talks about all essential or priority or basic services. And that wording has been introduced into the international conversation gradually since 2005 until today. Mostly the term essential is used, but sometimes you'll see agencies and others talking about priority or basic services. So SDG goal 3.8, quoted here, achieve universal health coverage, including financial risk protection, access to quality essential healthcare services, and access to safe, effective, quality, and affordable essential medicines and vaccines for all. So question one, what are essential health services? And who determines what are essential health services? And question number two, and a little footnote here, it's worth noting that this qualification for health services coverage of essential is not applied in these statements to financial risk protection. So in some ways, the goal seems to imply coverage for a subset of all services, defined as essential, but financial risk protection related to all services, not only essential services, right? And so this is an element of uncertainty, I think, in this global conversation that hasn't been clarified and hasn't been resolved. Why does this matter? Well, you can imagine service delivery programs focusing on a subset of services, but if you want to provide financial risk protection comprehensively, then there needs to be some other kinds of social mechanisms that are, or action mechanisms that are not simply related to a subset of services, like universal health insurance or universal free or very low-cost care through public delivery and so on. And we do see countries struggling to find how to apply these definitions. Okay, and just kind of dig in a little further into some of this documentation, just because I think it is important. It's setting the conversation in the global agenda. This is from the 2019 Global Monitoring Reports. These are the documents that I showed you the covers of earlier. They are official reports by the World Bank and the World Health Organization to the United Nations community, requested by the United Nations community of states. The GMR Global Monitoring Report actually comes out annually. I actually, when I worked at the World Bank, I had a chance to work on the Global Monitoring Report around the MDGs at that time, and I guess it was in 2009, I think, or 2008 or something like that. But this is now focusing on UHC. So just to read a little bit from this, universal health coverage means that all people receive the health services they need, including blah, 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 blah. I won't read all the long subtext there, while at the same time ensuring that the use of these services does not expose the user to financial hardship. So again, in 2019, the meaning is all the health services they need without financial hardship. SDG Target 3.8, achieve universal health coverage. You would think, looking at this document, that that means what it says in the preceding paragraph, right? But it includes financial risk protection, access to quality, essential healthcare services, and access to safe, effective, quality, and affordable essential medicines and vaccines for all. So here again, even in one, copied box from this official document in 2019, this question still haunts us. And then you can see below coverage indicators. The target 3.8, indicators of the target 3.81 and 3.82, distinguishing between two dimensions of UHC, coverage with services and financial risk protection. And then this is basically what's being monitored globally. Indicators of coverage of services and indicators of financial risk protection. Just to come back to some of the earlier conversation about this, I think it's important to understand that the term coverage has been used in different ways by different interest groups in the health system. Coverage really has two distinct meanings, I think, in our healthcare discourse. The term in terms of healthcare utilization and access has been defined as the percentage of the population who need a particular service and receive that service. That's coverage, service coverage. So, for example, if all pregnant women should receive antenatal care, then the percentage of pregnant women who receive antenatal care is the coverage with antenatal care. And we could qualify it even further, and the international agencies do that, saying that they recommend 4 antenatal care visits, so what percentage of women receive 4 antenatal care visits would be a further refinement of that indicator. It's been modified further with the notion of effective coverage. And effective coverage can be defined as the percentage of the population who receive a needed service at a level of quality sufficient to produce the intended outcome. Okay? So it's kind of a notion of adequate quality, that the quality should be sufficient to produce the outcome. So you could adjust measures of utilization and access, coverage measures, by quality to get this measure of effective coverage. In the financing area, though, coverage means something different. Insurance organizations typically think about coverage as the percentage of population who have received an entitlement to some kind of financial benefit. This doesn't necessarily mean that they actually receive that financial benefit. They could choose not to use that entitlement or not to use it fully or use some alternatives to it. So, for example, your entitlement might be full financial payment for a certain service from certain providers, say public sector providers or social health insurance providers, but you might choose to go to the private sector and pay out of pocket for that service, right? In which case you would have received the entitlement of financial risk protection, but you would not necessarily be protected in the same sense. So these two meanings, I think, are important to keep in mind because they do imply different outcomes. And some people have said we shouldn't use this term coverage. An editorial by David Sanders in The Lancet in 2019, and unfortunately we lost David Sanders also in 2019, but he said in his editorial that we should drop that term coverage and use the term universal health care. Okay, so another topic of debate. If you look at this, how many of you are familiar with the so-called WHO cube? I know there are a lot of PhD students here, so you should be. WHO produced this in 2010 in the World Health Report, this nice graphic of what a health system should be doing to achieve universal health coverage. They basically had this cube with 3 dimensions: population who is covered, services, which services are covered, and what proportion of the costs of those services are covered. And the content of the cube was described here as current pooled funds. So you can see there's a focus on financing here. And universal coverage would be achieved when the blue part of the cube filled the whole cube. All services were covered for all people, with 100% of the cost of services being paid for by pooled financing. And in some versions of the cube, this has been replaced not as current pooled funds, but as service coverage or something like that. So again, this is a useful graphic to help us think about where we are in terms of UHC, but we need to think about it not simply in terms of funds and financial protection, but in terms of service coverage and service access. Okay. Let's now look at monitoring progress and see what we can see about what's being reported to the world. So WHO and the World Bank have put forward a monitoring framework. This global monitoring report basically is the latest version of the data that they've been collecting, and there's indicators that are being reported both for service coverage and financial risk protection. And I want to show you a little bit about how that's being done. So there's 2 sets of measures: service coverage and financial risk protection. They're consolidated into some summary measures, and there is a proposal to develop something that has been called a UHC index, which would consolidate them further, which would combine service coverage and financial risk protection into a single measure. Now, with so many PhD students here, I hope you all know that when you combine many indicators into a single measure, sometimes you don't necessarily see in depth what's going on, and there are many issues about doing that. But of course, for monitoring and policymakers, people like to boil things down to a single number, and so that's really where things are going. So let's look at the 2 dimensions separately. This UHC index has not yet been produced. It's proposed. So this is the service coverage index, and it is a summary based on indicators of 14 different measures. One set of measures about reproductive, maternal, newborn, and child health, family planning coverage, antenatal care, 4 visits, child immunizations, DPT-3, and care seeking for suspected pneumonia. So these are measures for which you could calculate a coverage number, right? And infectious disease is the second category. TB, effective treatment, HIV treatment, coverage with insecticide-treated bed nets, and at least basic sanitation, whatever that means. And it does have a meaning. I'm being a little sarcastic. So, non-communicable diseases, attainment of normal blood pressure, mean fasting plasma glucose related to diabetes, and being given advice on non-smoking, tobacco cessation, and so on. And then 3 service capacity measures: hospital bed density, health worker density, and I don't even remember what IHR is. Does somebody know? Anyway, some service capacity measure. Anyway, the point I want to share with you is that what's done is these are all measures in percentages, right? And then they are added together in a kind of a through the geometric means of these measures, and out of these is created a single UHC service coverage index. Okay. Now, this clearly is more related to essential than it is to comprehensive UHC. Okay. And this is the data that's now being monitored for all countries on service coverage. For financial risk protection, two types of measures are being used. One is called catastrophic health spending, and that's defined as the percentage of the population whose out-of-pocket health spending exceeds some benchmark of total household consumption spending. So it's out-of-pocket spending on health care as a percentage of total household consumption spending, right? And then there's different benchmarks that are used, and I'll show you some examples of that. And secondly, impoverishing health spending, which is defined as the percentage of the population who would be below a defined poverty line after deducting out-of-pocket health spending from total consumption health expenditure. So the idea here is that if you're spending so much out-of-pocket on health care, does the remaining consumption expenditure in your family put you below the poverty line, using various measures of poverty line? Okay. So what do we see looking at the data? How's it going? So this is a map of country-level service coverage index values in 2017, okay? And ranging from the darker color, 80 or more, that's that summative percentage across all those different coverage measures, right? The 14 measures. And less than 40 is the lighter color, okay? And not surprisingly, we see what we probably would expect to see, that the lower income countries tend to have lower levels of overall service coverage index, and a few countries have the higher levels, US, Canada, Australia, some of Western Europe, but not all, and so on. So there clearly is variation across the world. This chart shows the trends in improvement across different regions of the world and different income groups of countries. Now, this data only runs to 2017. SDGs technically began in 2016, so this is the initial monitoring. But most of these indicators, maternal and child health, infectious disease, strengthening basic health systems, were also part of the MDGs. So we do see, and the only part of these indicators that was not part of the MDGs were the non-communicable disease indicators. So we do see significant improvement trends across the world over this period of time, with Africa and parts of Asia lagging. And similarly, we look at low, middle, and upper income. We see clear differentiation across the world in terms of country income levels. Again, not surprising, but upward sloping progress in all parts of the world, and progress at fairly similar pace. So, and in some ways, this represents, I think, some of the successful experiences from the Millennium Development Goal period, where many of these indicators were really focused on, and they were, there was significant progress being made. If we look at the this looks at the capacity and access component. These are the service delivery parts. The picture is much flatter. There hasn't been so much progress in achieving improvement in the service capacity measures. Important to keep in mind, especially with the low and lower middle income countries, some of these are related to population. So you have expanding health system capacities, but also population growth, rapid population growth still taking place. Okay, and this takes the same measures and looks at the annual change in capacity. And there are some outliers, but fairly modest change in those things, the health system related things over this period of time. Looking at the pace of progress on the service coverage index, and this was really, I think, one of the important things that the international agencies put together. We see that the rate of change in the overall service coverage index rose rapidly in the early period of the MDGs, but has been declining somewhat since then, okay? And that we do see, if we look at that by the income level of countries, we see some troubling changes, especially in the low and lower middle income country groups. That rapid increase initially in the MDG period, but even in the low income countries, moving to an absolute decline in the two more recent years. So very much a challenge. And the report then concluded that if recent trends continue to 2030, the world is likely to fall well below the SDG target of universal coverage for all essential health service coverage, right? And this is a projection and the target of 100% universal. You achieve UHC for all, and just keep in mind that these indicators measure essential coverage, not comprehensive coverage, okay? So this was a very disturbing result. Looking at financial risk protection, also we see, some very interesting, important reporting, okay? So this is the top two diagrams relate to out-of-pocket spending exceeding 10% of the household budget, okay? So, and this one, 25% of the household budget. And you can see that the first chart relates to the number of people affected, the size of population. And the second chart here relates to the percentage of the population in the different country groups, okay? So you can see some interesting phenomena. You can see that for the low-income countries, there seems to be a trend for both of these levels of improving excuse me, financial risk protection measured as the out-of-pocket spending as a percentage of total household consumption. But for the lower middle income countries and for the upper middle income countries, some evidence that the expenditure may be, out-of-pocket expenditure may be increasing as in relation to household consumption expenditure. This is very interesting because one element that we're looking at in financial risk protection is that as people's income rise, their demand for health care may increase more rapidly so that very poor populations really can't afford to pay much out of pocket for health care. But when people get a little more economic capacity, purchasing health care in the market might be more attractive to them. And even when public programs exist to provide financial risk protection, they may choose still to purchase health care in the market at an increasing rate. And so we're seeing some evidence, and interestingly, I think this is partially what some of the research in Mexico has been showing, that even though there was an effort to provide pretty comprehensive financial risk protection, people are still spending out of pocket, not because they're not getting this financial risk protection, but because their demand for health care still exceeds the capacity of the system to deliver that. So this is one measure and if we look at various benchmarks for impoverishment, $1.90 per day, $3.20 per day. These are arbitrary cutoffs set by the World Bank, and 60% of median consumption. I won't go into the details of what these are. We do see that there are some interesting trends that for the 60% of median consumption measure, there does seem to be some increase in the number of people experiencing impoverishment by that benchmark, but not for the other two measures. And this is the percentage of the population and the size of number of people, size of the population there in numbers. So, you know, some, I think, very important, useful presentation of global measures that help think about what we're seeing in terms of progress towards UHC. So let me see if I can now try to pull together what we see from these data and then give you some concluding thoughts, and then we'll have some discussion. So in practice, UHC progress for lower and middle income countries has been mostly about essential and not comprehensive UHC. And I think that this is an important thing to understand when we think about achieving UHC by 2030. Now, achieving UHC for essential services, however defined, would be a fantastic step in progress towards global health. And so I don't mean to in any way downgrade that, but I think it is very different from what the original ambitious ideas about UHC were in 2005. There's been significant progress in service coverage, but there are large differences still across country income groups. And I haven't looked in this at the differences within countries, but they also significantly do persist. And there's been some really excellent work done initially by a global monitoring group called the Countdown to 2015, which looked at maternal and child health indicators and looked at the work of Cesar Vieira and others in that group, explored the question of when you increase coverage for the population on average, do you increase or reduce the disparities within the population of coverage? In other words, do you mostly increase coverage through benefiting the better off people in the population? So this equity question is very important, and we found a very mixed picture in countries of this kind of equity picture with increasing coverage. And this was looking mainly at income differences, but you could look at urban-rural differences, gender, and so on. Financial risk protection progress has been very mixed, and it's not easy to interpret it. We have these simple indicators of out-of-pocket spending and impoverishment, but it's not entirely clear what they really mean in terms of the impact on households and so on, because they're fairly simplistic measures comparing spending against some benchmark, right? And households do a lot of things to buffer the costs of healthcare, savings, borrowing, family, and so on. So while these are important effects on household well-being, they may not be catastrophic or impoverishing. And I think that's important to keep in mind. So importantly, I think for the world, the WHO, in response to this meeting in September, summarized, despite the progress, UHC coverage is stalled or not on track, and only about half the world's population will be covered by 2030. Therefore, we must markedly accelerate progress, double the coverage in order to achieve the target of UHC coverage by 2030, essential service coverage. And I think it's worth noting that this has also given rise to some new work on how much money it would cost to achieve UHC. Now, this is complicated by the fact that which UHC are we talking about? But for those of you who are interested, there was a very interesting paper published this year. First author was Karen Stenberg at WHO, published in The Lancet, which provided some estimates of 3 levels of healthcare coverage. One with a kind of basic primary healthcare, which is really mostly outpatient and infectious disease services. One with a kind of primary care plus package, which would involve some very limited hospital-based care. And you can imagine one of the complications in this is that deliveries, maternal deliveries involve not only primary care, but often hospital-based care. And one with a somewhat more comprehensive package of services. And the numbers that they came out with really were at levels that greatly exceed what most low-income countries and many lower middle-income countries are spending in terms of government-provided health care. So something in the neighborhood of $90 per capita per year to finance the basic primary care package, and somewhere in the neighborhood of $150 to $200 per capita per year to finance a package with some hospital-based services, and still not comprehensive. And we're looking at many lower middle income countries where governments are spending at levels of $5 to $25 to $30 or $40 per capita per year for some of these services. So in many countries, a doubling, a tripling more needed in terms of public finance to achieve these goals. Very ambitious goals. So some thoughts. Globally, I think UHC is a very ambitious and aspirational goal, especially by 2030. My political scientist friends tell me ambitious and aspirational goals are great to have, and they're what we need to motivate people to do things. I'd say personally, I also feel that there are some risks to having overly aspirational goals if they be seen as not attainable or not realistic and so on, and create some feeling of discouragement. But I leave that to you to figure out how you feel about that. I think that the international discourse has clearly pulled back from the ambition of comprehensive PHC, and it's focusing on comprehensive UHC, and it's focusing on essential UHC, and the measurement that's taking place is really focused on essential UHC. There's been a lot of progress, but we are currently, the evidence tells us we're lagging well behind what's needed to achieve even this essential UHC by 2030. And what's been, I think, particularly also important is that in the years since the SDGs were launched, several other very important issues have been gaining rapid ascendancy on the global agenda, most remarkably climate change, and that the resources from the global community to address UHC progress, the evidence tells us, are not increasing, may be declining or at least remaining flat. So there's a question about how to balance all these different ambitious goals and priorities. I think that there is some concern about having this focus on comprehensive UHC, and we do see some lower middle income countries launching major national health insurance programs promising comprehensive UHC to their populations without having, in my view, anywhere near the resources available to achieve that. And what will be the consequence of these promises made to populations which may not be able to be fulfilled, I think is an important issue going forward. Indonesia is one example of that. India is another example where major promises have now been made by the government to provide health insurance coverage to Indonesia now has the world's largest single-payer social health insurance scheme. India is promising to cover 500 million people with its new national health insurance program. We'll see what happens with that. But UHC is going to be with us for a while, and I think it is a wonderful and important and aspirational goal. But we will, I think, be having this conversation many times in the coming decade about how much progress is being made and what we can do to accelerate and improve that progress. So I'm going to stop there, and I will ask you to think about the question, where is Canada in terms of achieving UHC? Thank you.